Welcome to the Sustainable Clinical Medicine Podcast. I am your host, Sarah Smith. I am a practicing rural family physician and the charting coach. This is the podcast for physicians and advanced practice providers who are ready to step back from the busyness of their clinical day to share ideas, question everything, and redesign their clinical day. We are redesigning clinical medicine to create sustainable clinical days and create time for our lives outside of medicine. Join us for discussions with world experts who are helping design sustainable models of clinical medicine and the physicians or clinicians who have discovered or designed sustainable models of clinical medicine for themselves. Hi, everybody, and welcome back. Today, I have a very special guest and friend, Sue Peters, who is doing some great work in the space of helping family doctors, hooray, in the area of figuring out their teams and systems to help them in the best and most wonderful way. So, Sue, I'm going to let you introduce yourself and how you came to be here.
Yes, thanks, Sarah. My name is Sue Peters, and I'm a healthcare consultant supporting both specialty teams as well as primary care teams across Canada. And I'm actually an audiologist by training. I used to work with very, very deaf preschoolers. And as I became more interested in quality improvement, and I just love to learn, and I found myself in becoming an expert in quality improvement. And so I've worked with the Alberta Medical Association for 8 years. I just recently stepped down, but that's where I met you, Sarah, in some of the work that we were doing around patients' medical home development in Alberta.
Yes, in fact, Sue was exactly where in my world when I was at the point of hearing the primary care networks come out with 2.0 evolution. And there was this tiny little video that said, we're creating this sustainable model of primary care and physicians will get home with today's work done. They said that at the start of the video, and then there was nothing else about that in any of the material. And I was so offended and upset because when I met Sue, I was probably had an attitude of, stop giving me things to do. I don't want anything else. I'm already too busy. You don't understand. I'm too busy. I can't do anything differently. And Sue was the person who just kept showing up to show us how to get things off my plate, to stop having to do the not physician work. And I think this is where it's so interesting that somebody was there in the before and the after. And so you've just been such a pivotal person in there that I just wanted to celebrate that a little bit and kind of help everyone remember I was right there with y'all.
Yeah, and it's been my delight to watch you evolve over the years, Sarah. Like it's just so much fun.
Yeah. So tell us the kind of mechanics of what you do, because it's kind of interesting and I'd like to hear it from your perspective.
Yeah, so I was trying to reflect on what actually do I do, and I there's basically two aspects of my work. I am helping jurisdictions implement patients' medical home work, which is what I did when I was with a consultant with the Alberta Medical Association Accelerating Change Transformation Team. And I know you have had Michelle Henney on your podcasts, and Michelle and I worked very closely together on that team. And when I was doing that role, my role was really to help teams develop the the capacity for improvement. So helping to put those structures in place to support quality improvement, the sequence to achieve change, the model for improvement. How do we do small tests of change to get better? And then I also, as part of my work, was helping to develop physician champions and other champions. And so that's how we started working together too, was we're like, oh, she's going to be great as a physician champion. And how can we help you move along? Sometimes I get involved with physicians when they take on leadership roles within, whether it's primary care or specialty care, and they can no longer meet the needs and the demand of their panel and their patients. And I kind of come in to help them navigate through that and talk about what are some of the possibilities, right?
Mm-hmm. So when I'll just kind of expand that into a little bit wider so people who may not understand what that means. So patient medical home is the place where the patient is understood to have their healthcare professional and the team that look after them. So it's a place where things like the specialty letters will come into, and that is then actioned, and we try and do the preventative care for the patient, but we're using more than just the physician to do the work. So there's some way of engaging the team.
Yeah, exactly. And the way I like to think of it is that a lot of physicians right now are out there being solely responsible for the care of the patients. And it looks like I've frozen again.
That's okay.
And now what we're doing is a team around our patients, and one of the team members happens to be a physician.
Yeah. So we're creating a team. And that's what I really like. And it's a challenge for physicians to do that. It really is. Like when Sue was talking about somebody going in ahead of me to look at my inbox, I got really anxious. It's probably the best way to explain that.
Yeah, for sure. And with establishing a quality improvement team, we build out processes. So it's not just anyone going into your mailbox and inbox and managing things for you. They're following very particular protocols, and that has to be built over time. So you may feel comfortable not actually seeing the mammogram results if they're normal, that they come into your inbox and someone's role is to review that, to update any screening and prevention in the EMR, and then that is available to you when you see the patient next or when you need to review their chart, but it's not something that you have to spend time on.
Yeah. And so we know that physicians and clinicians in that expert role won't use a system if they don't trust it. And so this is where the trust piece and the quality improvement piece is built in, that we create robust systems that, one, we can monitor who's been in there and what have they done. So kind of reviewing that communication piece, and that the work is being done in the way that will create that safety net for your patients, which I think they're the pieces that, because otherwise we get really anxious physicians who want to handle and tick off all the boxes.
Right. And I feel like really it's helping to distribute the responsibility amongst a team that has your back, and that doesn't happen overnight. Like there's a lot of team building that needs to happen, and we need to start off slow. And once we get one thing accomplished and a physician is feeling comfortable, then it's time to move to the next thing. And just knowing that we're, very much putting these standard processes in place. And one of the challenges that we face is that we have a lot of clinics where the physicians are actually practicing alone together. together. So they might be in the same clinic, they might be sharing an EMR, but their processes around how they do things are all completely different. And so part of my job is to actually wrangle all the physicians together to say, okay, well, we need a standardized process. So it won't matter which medical office assistant you have working with you, or which LPN you have working with you, or which RN you have on any given particular day, because they all do things the same way. And it's about coming to agreement on how we're going to do things in our clinic. And it may not be exactly what we want, but we can live with it. And it's trying to find consensus about what we can live with, striving for that standardization and to have things run smoothly if your LPN happens to be out that day.
Mm-hmm. Yeah. When I first arrived in Canada, I had intended to be here for a year. And I know, 11 years later, folks. And when I got here in Australia, we have this understanding, for better or worse, that it's the physician's job to make sure that if you have a pap smear this year, that you get reminded in 3 years or 1 year, whenever that is supposed to happen again. It's on the physician to remind the patient. So we kind of took the patient responsibility out of the equation and left it in the hands of the physician and their very, for better or worse, EMR reminder system.
Right.
And I got to Canada and there was no reminder system at all. So unless a patient was in front of you, you weren't even going to know whether to go look and see if they're up to date with their screening.
Mm-hmm.
And that created a lot of anxiety for me and a lot of time in every encounter, right? So
Right.
patient comes in for whatever, sore knee, and suddenly you're scanning the file because they haven't been in for 6 months, 12 months, looking for when was the last this and that, pap smear, mammogram, colonoscopy, whatever that is. And when I realized this and I was going to be gone in a year, I wanted to create a safety net for my patients for when I wasn't here in 3 years' time and their pap smear was due. And so I started to work with the small skeleton team who were within the medical center at the time and say, who could ring the patient in 3 years and remind them to come back for this pap smear? And starting that process, knowing that if I leave like I'm intending to leave at that point where I had decided to go, could there be systems and processes in place? And fortunately, Sue came along with her team from the Alberta Medical Association and the good resources they had for setting up that processes within the clinic for setting up these types of things. So it wasn't just on the physician.
Okay. Apologies for the technology issues, Sarah. But when I got booted out of the meeting, you were talking about, having screening and prevention and relying on your EMR to be able to tell you when patients were due for things. And that's really one of the premises in patient medical home work, is to make the EMR the hardest working member of the team. And I would argue that provided that the EMR is accurately identifying who is due for screening, that screening is not physician work, that it's teamwork. And really, in some patient medical homes that are very advanced, any team member can be tasked with addressing a screening that is due or overdue. For example, if someone sees that their patient calls in and they can see that they're due for colorectal screening, that they can be empowered to be able to book that appointment or to advise the patient on how to do that. And actually, I was diagnosed with breast cancer in 2016, And, you know, it was so surreal because I was teaching teams how to do better screening and how to leverage the EMR. And I belong to a patient medical home, and I went to see my team. And when I checked in with reception, they noticed that I was due for a mammogram and gave me the requisition right there, even before I had gone in to see my physician and team for a completely unrelated thing. And really, that team and the work that they had done as part of developing Patient's Medical Home really saved my life because I was diagnosed with a stage 1, but it was grade 3 tumor that was very nasty. And so I'm really grateful to the work that Patient Medical Home did, and the team, you know, the steps they took, and then the supports that they received from primary care networks and others within the system to help move that forward.
Yeah, so powerful. Just hearing it from the other side that your busy physician didn't need to do it, and yet the team and the EMR did the work and created this opportunity to look after you.
Right. Yeah.
So helpful. So we've got studies that are saying if we were to do primary care in the optimally as physicians only, is 27 hours a day of work, right?
Yeah.
So we don't have the time to do it well. So we're not doing it well, which is where we need to create these teams with the staff that we have and with the EMRs that we have. So we hear that the administrative burden is so incredibly large and proven to be so. And we're saying it doesn't have to be you.
Yeah. And you know, when I talk with physicians who often find their way to me because they're in crisis and, you know, they're trying to establish work-life balance, they're trying to take a holiday where they don't have to take their inbox and EMR with them. And they've tried everything to rearrange their schedule, trying different templates, trying all of these. And then when it comes down to it, it's like, you need a team is what you need. And the only thing that's going to help you is a team. And because, you know, a lot of times when a physician is solely responsible for the care of the patients, probably 70 up to 75% of what is being done in your day is actually could be done by someone else on a team. And we want to free physicians up, whether it's specialty or primary care, to do the work that they're highly trained for and not have to worry about things that are better done by other people, actually.
Yeah, better done by other people because they have the time to do it.
Right.
The difference when you've got a worker who is able to make the calls and check in with the patients and get them like the results that they are looking for and working on behalf of you, they can get through them because they're not doing all the other things that you're doing within your day, within your care of those patients who are booked in for today.
Right.
Fascinating to me.
Right.
I'm like, how did they get through that list so quickly? Oh yeah, that's what they did all day. Like I did all these other things and they were doing that bit.
Right. Yeah. And you know, it really allows team members to be working top of scope. And that's what helps keep them, it's a great retention approach, because people who are working to top of scope really enjoy their jobs more because they feel like an integral part of the care of patients. And that's really what we're trying to establish. We know that reception and your medical office assistant who's calling patients, they know the patients so well because they talk to them all the time. What really I love to see is when a team has so much psychological safety and they're all focused on the care of patients, that a medical office assistant who's talking to a patient that could say, I just spoke with Mrs. Brown and she didn't sound very good, and I'm really worried about her, and can we bring her in because I'm worried about her. And that team member is so empowered, and so it really feels like a critical part of the patient's care team, and everyone in the clinic has that role, and that's what we're trying to establish.
Yeah, I think that's important, because we're seeing a lot of physicians explaining that the retention of staff is so difficult, and then the
Right.
onboarding of new staff can be so difficult if we haven't established really good onboarding, which means really good systems for what you'll be doing within this team.
Right. And it's interesting, because some of the teams that I've worked with, they've taken a stab at trying to create that team environment, like collaborative health practices, family health teams, some of the teams that you see across Canada. But when I start working with them, they really don't have those structures in place for quality improvement, like regular quality improvement team meetings. And I mean weekly, even if it's just for half an hour, that the team gets together and talk about how we're going to change the work. And it's, and like they're just a team, and they're not necessarily working to top of scope. And they tell me, oh, we implemented a UTI protocol that LPNs can see the patient, and they look for any red flags, and provided there aren't any red flags, then we follow this protocol. But I'm like, well, where is it? Did you write it down? And it's like, oh no, well, we didn't actually write it down. Does everyone do this? Like, are you sure? You've had a lot of turnover in team members. Do they all know what they're supposed to be doing for that? It's like, no, maybe not. And so it is, having the rigor to document those processes, and then they can be really fabulous job aids when you're bringing on a new team member to help them understand what it is we do in these circumstances. And again, it just makes life so much easier when you have a team member who really understands how we work in this clinic, and it makes when someone is away not as painful, that your day can still go well because everyone really understands what their job is.
Yeah, I think that is an asset to your business when you set up a process that's easy to explain to others. And so you've got multiple members of the team who can be overlapping in taking on those tasks, so that we don't have that lapse. If somebody's away, like you said, or we have a staff turnover, it's easier to onboard somebody than having to take a lot more time to get that person up to speed. Yeah, so important. What about when teams are small? Because we know that staff costs are expensive, and a lot of physicians are taking on that cost of staff themselves as part of the cost of doing business. Optimization then. Have you come across small teams?
Yeah, and I mean, every team is different. What I would say in terms of, and I'm pretty sure we had the conversation, Sarah, back in the day, was the return on investment in medical office assistants. And, there was a physician who was one of our champions at the Alberta Medical Association, and he went down to a conference. It was the Institute of Healthcare Improvement, fabulous conference, by the way. I went last year in December, and it was fantastic, and I'm going again this year. But he went to a conference, and he heard a talk by a primary care physician who said, you can look after a panel of 6,000 patients with a team. And he was like, there's no way. And he goes, yes, way. And so he came back to Alberta and started he hired 2 summer students that year, and said, I want you to follow me around, and write down anything that you think you could do right now, or anything that you think you could do if you were trained how to do it. And that's when he realized that 75% of what he was actually doing was not physician work. And so he hired, these medical office assistants, and because of he was able to, max pack his visits and be able to provide all of the care that patients needed in that visit, keeping in mind we don't want to, have a 15-minute and turn it into a 30-minute appointment, right? Because that's going to not keep you from leaving on time. But how can we use the team to help support that he was actually able to increase his billings by 30% in that following year. And so it is taking that leap, saying, if I can trust and I can, identify these things that could be done by someone else, and as long as we have a protocol to follow, what other opportunities does this give me in terms of providing care to the patients? And what we know from some of the evidence from the Health Quality Council of Alberta, looking at Tabor Clinic and Crowfoot Medical Clinic, that are patient medical homes that have been doing this for a really long time, is that they are able to see more patients or to manage more patients on their panel because they have a team that supports them in all of that work.
Yeah, I think that one of the other obstacles I get kind of across my desk a lot is, how do I get this team wanting to take on more role and responsibility, or how would we get them to their best scope of practice when they've been here doing the same thing for a long time?
Mm-hmm. Mm-hmm.
Tell us about some of those types of things.
Yeah, and it really is baby steps. And it really is, forming a team, meeting on a regular basis, identifying those pebbles in your shoes, the mosquito in your tent, and say, okay, how are we as a team are we going to address this? How are we going to fix it? And the really critical part of that is that you have representation from every role in their clinic, and everyone has an equal voice in those quality improvement team meetings. And so how are we going to try it with one patient tomorrow? One patient. Like, it's not about boiling the ocean. It's taking one baby step at a time and moving in that direction. And when you try something, it's like consistent plan, do, study, act cycles, or PDSA cycles, when you're looking at the model for improvement. And it's like we want to know, after we did that trial, do we abandon what we tried, or do we adapt it, or do we adopt it? And then how do we try it on, another patient the next day? And it's constant, just expanding how we're doing it. Lots of times when people are working on quality improvement, they end up throwing the baby out with the bathwater, and it's like, oh, they just make it such a big test of change that it fails. And then it's like, oh, well, we're not doing that anymore. It's about failing forward and learning from some of the things that don't go well. Like, for example, a script. I tried it with a patient today, and it was a disaster. And so here's how I think we should change that, and meeting and huddling and being able to talk about that, and then say, okay, now let's try the new one tomorrow. It's about failing forward.
Yeah. And I think that is such valuable information when we've got teams that have been in one way for a long time, where we want to start to shift the culture and the mission and the outcomes. Because if it's just a whole lot of, I want this off my plate, I want this off my plate too, and this off my plate, then we're going to have some objection at the front end.
Well, and we have to be emptying the backpack of the other team members that are going to be taking on this work too, right? Like, we have to decide, like, what are we going to stop doing? Are there things that, for example, when teams are adopting a new EMR, especially if they're coming from paper, there's a heavy reliance on those paper charts. And if you're using both systems, like you're pulling the charts, that's rework, as well as maintaining the EMR. So how do we reduce that? Like, how do we make it so that we're stopping doing things that are contributing to them not being able to take on other tasks? And it's amazing to me on the number of things that come up. For example, looking at saying yes to patients when you're going to be saying no to somebody else. So the patient comes in and says, well, I always get yearly blood work. And so I want my yearly blood work, but there's no evidence or guideline to support that patient have blood work done every year. And lots of times teams just say, okay, we'll just do it. Just because it's easier than having the conversation with the patient. But it's not just about ordering the blood test. It's about, drawing blood depending on where you live. And that may be your clinic that happens. That's the way it is in Prince Edward Island. And then it's reviewing those results and then following up with the patient regarding those results. Like, that's a lot of work. And so how do we, if we say yes to certain people, we're saying no to somebody else. And right now, with the crisis that we're in, with not enough providers to be able to care for patients, especially in primary care, we have to be thinking about this and really thinking about what we're going to stop doing so that we can create capacity and space to take on those tasks that will really make a difference to patients and to provider workload. And and a lot of the things too, like regarding EMR, it's created a lot of bad habits that didn't exist when we had paper. So for example, Sarah, when you were working on paper, you didn't take all of your paper with you on vacation. You actually left and there was a plan in place for that to be managed while you're away. Well, that doesn't exist in every clinic that providers are taking their inbox with them, and then they're not getting the rest and break from their work that they need to prevent burnout. And so, how do we put things in place like, inbox management for the team while the provider is away? How do we schedule in visits with other providers knowing that someone is going to be away? Looking at locums, looking at ways to cover and post-vacation scheduling, like how do we ensure that when you come back, you're not inundated, that you actually have time in your calendar to be able to see patients that you need to follow up with from when you were away, and then new patients that are calling in. And we just need to build capacity so that you're not feeling like 2 days in, like, I never had that 3-week vacation and I regret going, right? That's not helping work-life balance.
I 100% agree. So important. So what I'm hearing is that physicians are doing a lot of work that is not physician work, that teams that exist right now, because we know a lot of you have a lot of different looking teams than you might have before COVID, and a lot of staff turnover. How can we also remove things from their backpack so that they have more room to do some of the work, and that increases their job satisfaction and more likely to want to stick around because they're now part of the responsibility roles within their clinical work or within the clinical space. Yeah, super good. Where can people find you, Sue, if they're interested in just learning more or perhaps using your services?
Yeah, so I can be reached by email at sue@petersconsulting, all one word, .ca.
Perfect. And we'll have that within the show notes as well. Anything else that you would like to share before we finish up our discussion today, Sue?
Yeah, I guess it's my hit list of recommendations that I have for teams and physicians that I work with is think about building a team around you. And I personally believe that, one of the ways we can help fix the system is by actually investing in primary care teams and actually funding those positions. So that's my belief, and that's what Prince Edward Island is doing with their patient medical home rollout. So I really feel like somehow we need to get these teams in place to be able to support physicians. And, thinking about carving out that time for quality improvement, because it's kind of like, that image of the caveman pulling the cart with square wheels and someone is standing there with round wheels. It's like people are so busy that they don't feel like they have time for quality improvement. And I tell them, you can't afford not to do this time and carve out this time, because the return on investment is going to be significant once we can create some of those quick wins. And that has been one of the things where I see patient medical homes really develop fast, is when they have those structures in place. Really important to engage with someone who has QI methodology, practice facilitation, and different jurisdictions have practice facilitators available. And any change you make, you're going to be 3 times more likely to succeed by having practice facilitation. And start small. Just start somewhere, take a baby step. Don't boil the ocean. Don't try to solve everything all at once. Just take one step and start from there. And in a year from now, it will be completely different. And the stories I hear is, I took my computer home with me, my EMR home with me, and it stayed in my bag the whole weekend. It stayed in my bag in the evening. And I used to work till 9 every night trying to get all my charting done. And it's really fun to see the results of team-based care and patient medical home really coming to fruition.
Yeah, I love that. Thank you so much for being here, and thank you for the work that you're doing in the world. And for those of you listening, figure out, how do we get you back in your expert role and out of the busy work that is best done by somebody else, especially your EMR.
Yeah.
Awesome.
Thanks so much, Sarah.
Thanks for your time, Sue.
Thank you for being part of the Sustainable Clinical Medicine podcast. If you'd like to learn more or join us to help you get home with today's work done, go to chartingcoach.ca. There you'll find all the information on the Premier Lifetime Access Charting Champions program that is helping physicians get home with today's work done, with all the proven tools, support, and community you need to create time for your life outside of medicine. We would love to see you there. Until next time, thanks for listening.